Next lecture is by our own Rucha Patil. She's going to talk on when and how to test for carrier status and prenatal diagnosis, practical issues. Every time we face this question, every time patient asks this question. And Rucha is a scientist B, National Institute of Haematology, ICMR, and her area of interest is hemostasis and thrombosis and rapid test, microparticles, and she is a very good speaker, and she has got multiple national and international awards, and she has got more than 20 publication index journal. Over to Rucha. Thank you.
Thank you, ma'am. So good afternoon, one and all, and I'll be speaking on the topic of when and how to test for carrier status and prenatal diagnosis and the practical issues. So to start with, we all know that Comprehensive Hemophilia Care Center consists of clinical care, laboratory diagnosis, rehabilitation and occupational therapy, and one of the most important aspects is genetic counseling and genetic diagnosis. Why is this? It's because we all know hemophilia is an inherited X-linked recessive disorder, and it is caused because of the deficiency of factor VIII or factor IX. These patients bleed a lot spontaneously or on trauma, and they are classified into different, that is severe, moderate, and mild, depending on their factor levels. So what are carriers to define them? Carriers are females who have the mutant gene for hemophilia on one of their X chromosomes and a normal allele on the other. And thus, they may not show any symptoms, but they have the ability to pass it on to the next generation. Majority of the carriers do not bleed, but 20% of them have low factor levels. So before going to the genetic diagnosis, we should know the inheritance. So to start with that, if a carrier female marries a healthy male, though that couple has 50% chances of their daughters being a carrier and 50% having healthy daughters. At the same time, if they produce a son, there are 50% chances that the patient is hemophilic and 50% chances that it is a healthy male. When you have a hemophilic male marrying a normal female, all his daughters are going to be carriers. Whereas that is because one X chromosome is inherited by the father. Whereas all the sons are going to be healthy, normal sons. Now, this is very rare. It happens only in consanguineous marriages. But when a hemophilic male marries a carrier female, that is when you have 50% chances that the female may be a carrier and 50% chances that you may this couple may produce a hemophilic daughter. That is, they have the mutant gene on both the X chromosomes. This is very rarely seen. Whereas coming to the sons, 50% chances there is the birth of a healthy son and 50% a hemophilic son. So before the who and why, who and how, most important part is why carrier and prenatal diagnosis. The main part is that it should be done for prevention. That is prevention of the disorder. For doing this, you need to identify the carriers, and antenatal diagnosis needs to be done in all the confirmed carriers. But there is one problem in hemophilia patients, that is 1/3 of the mutations are de novo. That's why total eradication is always going to be a question mark. So 40% of our hemophilia families have sporadic mutations, that is spontaneous mutations. This is the fourth type of inheritance, that is no inheritance at all. That is when a healthy male marries a healthy female and still produces a hemophilic child. So again, why should we do antenatal testing? It is to know the possibility of transferring the disease to the next generation. Termination of the pregnancy may be considered if found affected, to help the family prepare and to plan delivery. For females who have a low coagulation factor 8 and 9 levels, genetic mutation should be done. Knowing the genetic variant also helps in new treatments nowadays, like immune tolerance induction and as well as availability of the genetic new gene manipulation techniques. So the next question, how? For this, I would want to stress on very important point for all the hemophilia patients as well as clinicians. An accurate genetic test is only possible if you have an accurate phenotypic parameter in coagulation lab, that is a phenotypic report, along with a family degree. Pedigree. When I say phenotypic report, it doesn't mean only the factor 8 and factor 9 levels. It should be a complete coagulation report, including von Willebrand factor antigen, the activity, everything, so as to know for sure that this is the disorder and this is the severity. Then coming to the types of mutations in hemophilia. Intron 22 inversion is the most prevalent, that is 45 to 50%, followed by intron 1 inversion, which is 2 to 4%, followed by point mutations and then deletions. In hemophilia B patients, there are point mutations followed by deletions. Thus, having so many years of experience of antenatal testing, we have a strategy for prenatal diagnosis. So when all the DNA samples of the family members and chorionic villus sampling comes to us, first what is done is a VNTR analysis. This is done to rule out any maternal contamination. After that, what is first looked into is intron 22 inversion. If it's positive, a diagnosis is given. If negative, you then look into intron 1 inversion. So basically, the mutations are looked according to the prevalence. If this is negative, you go ahead with direct DNA sequencing. Here, 2 sets of exons are classified, that too depending on the prevalence of the mutations. Once a variant is found, the deleterious nature is checked with prediction softwares and the final diagnosis is given. Despite of all this, if still no results are found, you have to suspect large deletions, which is done by MLP. Similarly, for hemophilia B patients, VNTR analysis is done to rule out any maternal contamination. Direct DNA sequencing is done for point mutations. If nothing is found, you have to again suspect large deletions by MLP. Now, the important question: when and who should be tested for carrier and prenatal diagnosis? So, as looking into the inheritance, there are mainly 2 types of carriers. One is the obligate carrier. Obligate carriers are daughters of hemophilic fathers, a woman with 2 hemophilic sons, a woman with 1 hemophilia son, and another relative in the maternal side. Potential carriers are sisters of a hemophilia patient, cousins, aunts, all close relatives. So all these females in these families need to be tested for carriers. So I have a question. In a hemophilia family, if a lady has 2 or more normal sons, can we say that she's a non-carrier? Absolutely not. A carrier hemophilic mother can have n number of normal sons. Similarly, she can consecutively have 2 or 3 hemophilic sons. This is just a chance occurrence. As said in the inheritance, there are 50-50 chances of both. Who are the essential family members required for this test? We need a hemophilia patient of the family. That is an index case. It could be the brother, the father, the cousin, the maternal uncle. Then we need the mother, and then we need the female who wants her carrier status to be checked. Can only factor assays help in distinguishing carriers from non-carriers? No, it is highly inaccurate. We have seen so many of our carrier patients having normal factor 8 and factor 9 levels. Do carriers have a risk of bleeding? About 30% of carriers have less factor levels, that is 40 to 50%. The factor levels even depend on the blood groups, and therefore it is essential for each and every carrier to know her factor levels, especially if she goes for some surgery, etc. Now, another interesting question is, can a carrier female present like a severe hemophilia patient? So for this, I would want to discuss one case. We had a 23-year-old female present with profuse bleeding after a cut in her hand. She gave a history of similar episodes in her past. She had a brother with factor 8 levels less than 1. We did the investigations. The APTT was prolonged, 100 seconds. Factor 8 less than 1 and von Willebrand factor 97%. Then genetic studies were done to see whether she was a hemophilia daughter. When we checked the mutation, the brother was positive for intron 22 inversion, but the sister was not homozygous. She was a carrier of this mutation. So why was she presenting a less than 1 severe hemophilia condition? Further investigations on the X chromosome lionization showed that she was a case of extreme lionization. So yes, it's a very rare possibility, but there are very rare carrier females who do present like severe hemophilia patients. What is the ideal time to get tested for carrier status? This could be any time, but it should be done before marriage or before conception. Again, an important point to stress to all the clinicians and hemophilia patients: Finding out the carrier status after getting pregnant should be discouraged. This should be done before getting pregnant, so it's easier for us when the patient is pregnant to find out the status of the fetus. So what gestation period is ideal for prenatal diagnosis? So you have the first trimester diagnosis by chorionic villus sampling procedure, which is done in the 10 to 12 weeks. You have the second trimester diagnosis by amniocentosis, which is done in 15 to 16 weeks. Then you have the second trimester diagnosis by fetal blood sampling procedure, which happens in 18-19 weeks of gestation. Here, no genetic test is done. The phenotypic factor levels are done. So these are the fetal sampling techniques. And are there any risk associated with sample procedures? As per the Western literature, 0.8 to 1.6% of risk of abortion is said to prevail in chorionic villus sampling procedure. For cord blood sampling, the risk increases. However, in our experience, we have not encountered any procedure-related miscarriages. So can a carrier diagnosis or antenatal diagnosis report be kept confidential? Yes, all reports are kept confidential, given only to the female or the immediate family members. So what are the practical issues that we face? Everyone must understand that factor VIII gene is a very large gene, and thus it takes 7 to 10 working days to give a report. Not only that, there are not known mutations in a particular exons. There exists heterogeneity of mutations, and thus each exon needs to be screened very properly. Apart from this, hemophilia even has issues like de novo mutations and mosaicisms. So these are the complex, the practical issues which we face. Apart from this, the patients keep requesting carrier reports during prenatal diagnosis. I will come to this in the next slide. And the most important issue which we face is an inability of the family to give us an index case for reconfirmation. So many times patients come, and as I said, the phenotypic report is not properly done. Either the von Willebrand factor is not done, or the factor VIII levels look dicey. This is a major issue. That is because we are going into a dark. We are checking the factor VIII completely when later on you come to know it's a von Willebrand disease. So this is one issue which we face. Then other issues are patients asking us questions like, can we know the sex of the fetus? No, there will be only two kinds of reports. One is an affected report, wherein that means a hemophilic male. An unaffected report could mean either of these three, a normal male, a normal female, or a carrier female. No carrier report will be issued to the family at that time. For normal diagnosis, after a 1-year follow-up, the patient can come back. In case of a female child, the carrier or non-carrier status would be disclosed there. Can the blood samples be sent by courier? A question asked by many clinicians. For genetic diagnosis, yes, the samples sent by express courier does work. Our only problem is factor assays and the phenotypic diagnosis cannot be done. So, and we believe that a proper diagnosis, that is a phenotypic diagnosis, is necessary before going for the genetic diagnosis. So we advise most of our families to visit our laboratory where it is confirmed before going ahead. However, transport of samples should be the last option. Are there any misdiagnoses by DNA analysis? It depends on the method used. If indirect method of RFLP analysis is used, the risk of misdiagnosis varies between 6 to 9%. Whereas in direct identification of mutations, that is quite accurate. How to offer diagnosis when an index case is absent? So as I said, there is a high importance of having an index case because it makes it easy and accurate to give a genetic diagnosis. However, when the index case is absent, we can still offer the diagnosis because it is the direct DNA method, sequencing method. However, the accuracy may be slightly low. If we get a non-carrier status, it could still be a carrier because we may miss duplications, deletions without the index case. So I believe I have covered the how, who, and why, and I would like to summarize using the latest World Federation of Hemophilia guidelines. First of all confirmed carriers should be offered prenatal diagnosis. Second, genetic counseling should be done very properly. Everything should be discussed with the family, the inheritance, the chances of not getting a report, spontaneous mutations, the risk of the procedure, everything. Then, as I said, first of all, even in the World Federation of Hemophilia, the index case should be properly tested for phenotypically. You should know what is the disease for sure and the severity of the disease. Then after being confirmed that it's a hemophilia patient, you go ahead first, look into the factor VIII intron 22 inversion, and then the factor VIII intron 1 inversion, because these are the most prevalent. Once that is done and yet you get no information, you screen and characterize for small variants. This is done by direct DNA sequencing. If still uninformative, large deletions or duplications should be considered. Similar goes for hemophilia B. However, using the above current diagnostic genetic testing, if still you have no information which you can get, you have to consider other genetic causes like deep intronic variants which may exist. Not only that, if you find that the mode of inheritance is not conclusive, yet you have to test for 2N von Willebrand disease, the possibility of combined factor V and VIII deficiency and other types of von Willebrand. So these are the genetic diagnosis centers in India. We do believe that there should be many more centers and we aim for doing that. Thank you.
Thank you, Rucha. You covered extensively all the practical aspects, whatever we face every day, the issue of carrier testing and prenatal diagnosis. There are no questions. Actually, you covered so extensively, so there are no questions.